All right, well, thank you so much to our moderators and to Dr. Jazze and Barrett and Lemming for the very kind invitation. I'll be talking about updates on GU cancers from this year's ASCO. These are my disclosures here. And in 25 minutes, I've selected 4 abstracts that I'd like to talk about. One in bladder cancer, 2 in prostate cancer, which is near and dear to my heart, and 1 in kidney cancer. And the real theme that I want to emphasize is that I think in GU cancers, we're finally making progress and starting to catch up with our colleagues in breast cancer and lung cancer and doing better in molecular biomarkers to better select our patients for therapies. So starting with the bladder cancer, this was exciting data was presented by Tom Powles on circulating tumor DNA from the Niagara trial, which was perioperative durvalumab in muscle-invasive bladder cancer. And there was more exciting data that came out at ESMO this year that we won't have time to talk about. But where this came from, this was published in New England Journal last year, that perioperative durvalumab, when added to neoadjuvant chemotherapy, improved clinical outcomes, both in terms of event-free survival as well as overall survival. And so what this study was presenting was a pre-planned exploratory analysis of circulating tumor DNA and its association with clinical outcomes. So this was the design of the study. Durvalumab plus gemcitabine and cisplatin, followed by durvalumab versus standard of care gem-cis, a 1-to-1 randomization. And they used plasma ctDNA using the Signatera assay that many of us know and use. As you can see, as commonly happens in these studies, there were 1,093 patients who were enrolled in the ITT population, but in the end, only 462 patients were evaluable for ctDNA testing. That was the biomarker evaluable population. So the first step, of course, is to make sure that around half subset is representative of the whole patient population, which it seems to be. When you compare the biomarker evaluable population to the ITT, they're very similar in terms of their treatments, their age, sex, stage, et cetera. So a representative cohort, basically. And what they found, the first step is, does ctDNA positivity, does that change after treatment? You would expect it to, and for the most part, as you can see, as we move from baseline to neoadjuvant therapy, pre-radical cystectomy, and post-radical cystectomy, overall your rates of ctDNA positivity, the blue on the bar chart, is going down, as it should. And they did a number of comparisons looking at this at various time points. So first of all, and I think the real big finding is, at baseline, is your ctDNA status prognostic for event-free survival? And it looks like it is. Both when you look at it in the combined arms as well as per arms, those patients who were ctDNA negative at baseline did better. And they also showed that ctDNA clearance was higher in the durvalumab arm and was also prognostic for event-free survival. Particularly, you can see on the right, those patients who successfully cleared ctDNA had much better outcomes than those in whom ctDNA persisted positively. They also compared this with rates of pathologic CR, and so patients who did not achieve ctDNA clearance, or rather those patients who had pre-radical cystectomy were ctDNA positive, were highly likely to not achieve a pathological complete response. And post-cystectomy ctDNA detection was also prognostic for disease-free survival. You can see a clear separation of the curves between the ctDNA negative and positive groups. That was both overall and also when separated out by the arms. They also looked at the ctDNA negative population. Clearly, this was not as strong of a separation. So overall, it really seems like ctDNA status is prognostic for outcomes, and the clearance after neoadjuvant therapy was clearly associated with event-free survival. Of course, the study supported the addition of durvalumab to neoadjuvant chemotherapy, but as all good studies, I think it raised as many questions as it answered. So can we really start to apply this? Can we really start to use this for our treatment outcomes? So for example, can we de-escalate care for those patients who have negative ctDNA? And the dream is, can we maybe eventually even forego cystectomy for some of these patients? And on the other side, for those patients who have positive ctDNA at presentation or who fail to clear ctDNA, these are likely patients that are going to need further intensification of therapy. So more to come. But I think this is definitely one of the most exciting things coming out in bladder cancer right now. Let me shift gears now and talk about prostate cancer. And really the theme from ASCO for prostate cancer was molecular biomarkers, and particularly more focus on the homologous recombination repair defects and trying to figure out when to use PARP inhibitors alone and in combination. So this was a study that was published by, presented by Raina McKay, and it was in men with castration-resistant prostate cancer to bone, looking at radium-223 with or without olaparib. And so the rationale for combining olaparib and radium-223 is essentially radium is an alpha emitter. You can induce DNA damage breaks. Do you have synthetic lethality with a PARP inhibitor? And basically create these breaks that can't be repaired by the PARP inhibition. And there are some other data as well suggesting that there might be some epigenetic role here and possibly some hypoxia pathways as well that are involved. So they designed the study in patients with metastatic CRPC with 2 or more bone metastases, no prior RAD223, and prior docetaxel was allowed. This was a stratification factor, and we'll get to that in a moment. And they did it in a 2-phase design. So in phase 1, because of the possibility of increased toxicity when you add PARP inhibitor with radium-223, they actually did a dose escalation to figure out what the right dose of the olaparib should be. And so when they advanced into the phase 2 of the study, they used a lower dose of olaparib than is commonly used. It was 200 milligrams of olaparib twice daily, plus 6 cycles of radium versus radium alone. And the primary endpoint was radiographic progression-free survival. The baseline characteristics of the population were comparable. You can see there were about almost half of patients in both arms had more than 20 bone lesions on nuclear medicine bone scan. Nearly all patients had had a prior androgen receptor pathway inhibitor, and about half of patients had had prior docetaxel. Nearly all patients also appropriately were receiving bone-modifying agent, as they should be in MCRPC with bone metastases. Safety-wise, as you would expect, there were higher grade 3 or greater treatment-related adverse events in the combination arm, particularly anemia and decrease in lymphocyte counts, as you would expect with the addition of a PARP inhibitor. So the study did meet its primary rPFS endpoint with the combination. There was an improvement in rPFS, 8.9 months versus 4.7 months. And what I thought was interesting about this was when they did their pre-specified subgroup analyses, where you really saw the greatest benefit were in those patients who had not received prior docetaxel. Now, that is likely an indication of a better prognostic patient population. A patient population who doesn't require docetaxel up front is likely one that's going to do better regardless. Same thing, I think, holds with the number of bone metastases. We know that the number of metastases or the overall volume of disease is a good prognostic is a useful prognostic indicator in prostate cancer. And so those patients with fewer than 20 bone metastases did better with the combination as opposed to those who had greater than 20 bone metastases. And what was interesting was when they divided up the HR positive by HR negative, this was one of the surprising findings from the study. Now, these are all subgroup analyses. This is exploratory, hypothesis generating. This is not definitive. But actually saw improvements in the HRR negative group for reasons that are still unclear and might simply just come down to the small numbers that we're seeing here. The secondary outcomes, there did appear to be an improvement in the rate of secondary skeletal events with a combination. But I think one of the key weaknesses here in the study is that overall survival was not different. Now, overall survival was immature. The median follow-up was only 15 months in the radium-223 group and 19 months in the combination group, so it's still early to say. And it's important to note that there was crossover between the populations. But overall, I think this is an interesting study, and I think it's worth watching because we're looking at combining PARP inhibitors with other radioligands, for example, lutetium PSMA. And I think this study also bears out the importance of a lot of the prognostic indicators that we already know in terms of prior chemotherapy and rates of bone metastases. Now, the other prostate cancer study I'd like to talk about, and the one that I do think is going to be changing practice, was this study, the Amplitude trial, presented by Garrett Attard, which was a phase 3 trial of niraparib plus abiraterone and prednisone in patients with MCSPC with alterations in homologous or combination repair genes. So this was the first phase 3 study looking at this patient population. We've had a series of studies that was done in the early metastatic castration-resistant patient population, combining ARPI and PARP inhibition. This is the first one to look in the hormone-sensitive setting. So as patients with MCSPC and alterations in at least one HRR-eligible gene, BRCA1, 2, and you can see the rest over there, patients cannot have received a prior PARP inhibitor. They cannot have received a prior ARPI with the exception of abiraterone. They were allowed to have gotten docetaxel for up to 6 cycles, less than 6 months of ADT, and 45 days or fewer of abiraterone. It was a close to 700 patient trial, and patients were randomized 1-to-1 to the combination, niraparib plus abipred plus ADT, versus placebo plus abipred plus ADT. Patients were stratified by their HRR genes, including BRCA2, CDK12, and all other alterations. The reason that they separated, BRCA2 is, of course, clear. The reason they separate out CDK12 is that there are data coming out from other PARP inhibitors, particularly talazoparib, that CDK12 may actually have more favorable responses as well than some of the others. There was also stratification by, as we talked about, prior docetaxel and disease volume. The primary endpoint here was radiographic progression-free survival, and key secondary endpoints are listed there. The baseline characteristics, again, were well balanced between the groups. You can see here that high disease, most of these patients had high disease volume, 77% in the combination arm, 78% in the placebo arm. And there was a good mix of bone, lymph node, as well as visceral metastases. 16% of patients on both sides had visceral metastases. And more than half of the patients had a BRCA alteration in both arms. Safety-wise, the safety profile was basically about as we would expect. There was a higher rate of grade 3 or 4 treatment-emergent adverse events in the niraparib combination arm. There was not really a large increase in treatment discontinuation due to adverse events in the combination arm versus the placebo arm. It was about 15%. And when we break down those adverse events of special interest, the big ones, of course, that we look for with PARP inhibitors are hematologic. So there was a higher rate of anemia, a higher rate of neutropenia, and a low rate, but non-zero, of MDS in the combination arm. A higher rate of hypertension as well. So the big finding, the top-line finding, was that the Amplitude study did meet its primary endpoint of radiographic PFS. On the left is the BRCA mutant group, and on the right is the whole intention-to-treat population, the HRR mutant group. The hazard ratio, as we would expect, was 0.52 in the BRCA mutated group, so better, 0.63 in the intention-to-treat population. The secondary endpoints, including time to symptomatic progression, were also positive in both populations, primarily in the BRCA mutants, and this is something we commonly see across all the PARP inhibitor trials in prostate cancer. This is one thing that I think is very important to watch. The overall survival analysis is immature. This was just the first interim analysis. It hasn't yet met significance for the combination arm. But it does appear that those curves may be starting to separate, so we'll have to watch and see. Is there really an overall survival benefit? And this, I think, is going to be one of the biggest challenges with PARP inhibition and actually just in general, the crowded landscape we have now in hormone-sensitive prostate cancer. We have docetaxel chemotherapy, we've got ARPI, we will have PARP inhibitors, we will very likely have lutetium PSMA in the hormone-sensitive setting. And so we'll have a big problem in selecting whom to give these therapies to, particularly because these are patients who have a good life expectancy of several years. And so are these patients that we want to keep on PARP inhibitors for 2 or 3 or 4 years and potentially run the risk of therapy-induced MDS or some of these other complications. So that's a big open question in the field right now, I think. These are the subsequent therapies that the patients received. And you can see that most patients did receive any subsequent therapy. Nearly everybody received chemotherapy after coming off the study. A small number received ARPI afterward. That's appropriate. In general, we don't use very much ARPI switch. This is, I think, though, very important that only a small proportion of patients, only a third of patients in the control arm actually went on to receive a PARP inhibitor, even though these are all HRR mutated patients. And I do think that that is a challenge that we need to overcome in making sure that these patients are continuing to receive all life-prolonging standard of care therapies that they can. They did a subgroup analysis where they broke it down by the individual genes. And in general, the strongest signals for these, as always, are in the BRCA1 and 2 mutations. And that seems to hold true across the different trials, across the different PARP inhibitors. So I think the key takeaways, the primary rPFS endpoint was met. The greatest magnitude of benefit, as it often is in the BRCA1 and 2 patients. We're awaiting the overall survival data, but I think very likely, given the magnitude of this rPFS benefit, it's quite likely that this is going to enter the guidelines and enter the standard of care. The last study I want to discuss is in kidney cancer, and I thought this was an interesting one because it shows how even with a negative study we can learn a great deal from the biomarker analyses that come with it. So this is one that Monty Paul presented from Emotion 10, which was a study of adjuvant atezolizumab. Now, I'm not going to get into the discussion about adjuvant immunotherapy in kidney cancer. That's a hot topic. What I want to talk about is the biomarker that they studied. And so KIM-1 is kidney injury molecule 1. This is something that's been studied for some time and is a prognostic or a candidate prognostic biomarker in kidney cancer. This study a few years ago basically separated out post-nephrectomy high-risk RCC and showed that those patients that had highest levels of KIM-1 tended to do worse in terms of disease-free survival, tended to do worse in terms of overall survival. And so what the authors aimed to do in this study is they wanted to correlate KIM-1 with other biomarkers in blood and tissue and see if we can put this together to create something that would be more powerful and more prognostic. So this was the study design of Emotion 010. It was resected intermediate to high-risk RCC, randomized 1-to-1 to atezolizumab versus placebo, stratified by disease stage, PD-L1 expression, and geographic region. And the primary endpoint was investigator-assessed disease-free survival in the intent-to-treat population. So the study was negative. Those curves are completely overlapping. There was no difference in disease-free survival. So what they presented here was the translational study design, and this I thought was pretty neat. So they had the pre-treatment tumor, the patients who went on to surgery. They were randomized, and then in the patients who recurred, in a group of patients, they also had the post-treatment tumor, and they had blood that they collected along the way. And they did whole RNA, bulk RNA sequencing. You can see there were way more that they did at baseline, and they only had 80 at the time of progression. And they also did foundation medicine profiling as well on a matched group of 52 patients. So the groups here, they separated out their groups by a KIM-1 high or KIM-1 low. And there were a few things that were different between the patient populations. There were more patients from Asia Pacific in the KIM-1 high population, and there were more patients who had T3B, C, or T4 node-positive disease in the KIM-1 high population as well. So when they separated this out, they actually seemed to see there was, unlike the overall patient population where there was no benefit with atezolizumab, in this subgroup, there actually did seem to be an improved disease-free survival in the KIM-1 high subgroup with atezolizumab versus in the KIM-1 low. Now, again, this is hypothesis generating, this is not definitive, but it suggests that we may be able to separate out a population that benefits from atezolizumab in this group. And that might inform actually some of the other discussions we have right now about adjuvant immunotherapy in this patient population. So they wanted to understand better kind of what are the features of this population? Who is this population that's doing better? So they went back and they looked at they did RNA sequencing, and basically they looked at immune cell signatures. And they looked at effector T cells. So these are subsets of T cells that actually do the work that we want them to do, killer T cells, et cetera. And basically, patients in that KIM-1 high group who had more expression of effector T cells were the ones that did better with immunotherapy. This is what you would expect. And this is all at baseline. What you can do is they go and do these gene expression analyses. We won't go through this in all this detail, but it's all of the types of immune cells that you want to see when you're treating someone with immunotherapy. Effector T cells, what's known as Th1 helper cells. These are all cells that contribute to an anti-cancer immune response. They see all of these in the patients who had better disease-free survival in this KIM-1 high subgroup. So it's telling us that we can start to segregate out and separate out some of these patients who might do better here. And on the flip side, they wanted to better understand the patients who were doing worse. Who are the patients at the time of progression? What was going on in their tumors? And what you can see is there were more of these genes associated with the cell cycle. So these are cancer cells that are rapidly dividing. More of these cells that have immunosuppressive myeloid cells, so neutrophils, macrophages, more of the bad immune cells, and more stromal gene expression, so fibroblasts, these actual physical barriers that prevent our immune cells from migrating where they want to go. All of these are going up at the time of progression. And where I think this actually is going to inform the development of our biomarkers in the next few years is I think we're going to get away from a lot of these single agent biomarkers like tumor mutational burden, PD-L1 expression. Those biomarkers alone are just not going to be enough to select our patients in solid tumors because the microenvironment is so complex. You can think about there are cancer types that are what we call immune deserts. You have cancer cells and you just don't have any immune cells in there at all. Much of prostate cancer is like that, and that's why we've had so many failures with immune checkpoint therapies in prostate cancer. There are those that are what we call fibrotic or immune excluded. These are cancers that have got a really tight physical barrier around them where the immune cells simply can't migrate into where they need to go. You can think about pancreas cancer this way. You can think about prostate cancer, bone metastases that way. And then there are some where immune cells are free. They're immune enriched or inflamed. These are melanomas, and these are cancers that do really well with immune checkpoint therapies. And so part of, I think, our biomarker development is really going to need to incorporate these things, and a single biomarker like PD-L1 expression or TMB is not sufficient to do that. And so I think this study is a step in that direction. And there's other groups that are doing that. There's signatures. This is just one example. There's a company called Boston Gene that published on this. They have signatures where they incorporate these immune-enriched, fibrotic, non-fibrotic, and these are clinically available. This is not the only company. It's just one example that does that. So key takeaway points from this study is that in pre-treatment tumors, these T-cell gene signatures were actually associated with a benefit with adjuvant atezolizumab in KIM-1 high patients. There were markers of clinical progression that they found. Again, this is all hypothesis generating, but I think this does illuminate a path forward in terms of combinatorial biomarkers, and all of this, of course, would need to be validated prospectively. So I'm close to my 25 minutes. These are the 4 studies that we talked about, and again, the big picture here, where I think we're going in GU cancers, is really getting better in developing molecular biomarkers to select our patients. These are not all one-size-fits-all diseases, and I think that's what we're going to need to do to separate our patients and move forward in the field. I'll stop there. Thank you very, very much, and I'm happy to answer any questions.
Is this on?
On, yeah, okay. I will have kind of the same question Dr. Barrett has for what do you see specifically for bladder cancer, and I guess it's more of also the prostate cancer. The field is going. Mm-hmm. Specifically for the bladder cancer, the study of the Niagara is it's a water-shedding study that changed the practice for a couple things for me, because as you know, bladder cancer cystectomy is a big surgery in most of our patients. I wouldn't say most, but decent number of patients won't be able to get to adjuvant treatment. So getting these things upfront and seeing how it makes a difference in terms of clearing the tumor DNA by 13%, that is definitely a big plus for our patients. But I just wanted to see how this thing is going to go in terms of avoiding even cystectomy and predictive values down the road in terms of the adjuvant treatment.
Absolutely. So I'll start with bladder cancer, and then I'll talk about prostate cancer too, just because that's what's so near and dear to me. So I think in the bladder cancer world, you're exactly right. I think that we were talking about how one day we're going to look back and say that we were savages for doing chemotherapy. I think one day we're going to look back and say we were savages for removing people's bladders. I think having these ctDNA biomarkers I think will, in the near term, may help us select those patients for bladder preservation. And I think at the same time, if it can tell us who needs to be intensified, and if we can figure out who's developing a pathologic complete response, perhaps we may be able, even in those poor prognostic patients, to do bladder preservation. So I think the ctDNA, we haven't used it as much in prostate cancer, but I think in bladder cancer it's definitely changing the paradigm. In prostate cancer, I think we are in a stage where there's what I always tell my patients, there's an explosion of new therapies that are coming out. We've got, in phase 3 clinical trials, there's radioligands, not just lutetium, but also our alpha emitters, actinium, et cetera. There's new antibody drug conjugates, there's new T-cell engagers, there's CAR T-cell therapies, there's an enormous number of therapies out there. And now the therapeutic landscape is becoming really crowded. So what we now need to figure out is what is the best combination and sequence to give these patients. We need to stop treating our patients as a one-size-fits-all. We often have these discussions in prostate cancer. They're pre-taxane, post-taxane, pre-ARPI, post-ARPI, but we know that there's heterogeneity within those groups. There's some patients who are going to do really, really, really well. There's some patients where we even start using the C word. We might be able to cure some of these patients with the right combination of therapies. And then there are some who are very aggressive and who we need more intensive combinations. And I think once we get better at doing that, at molecularly selecting our patients, I think we can really start getting to that point of cure, and then I think even moving away from castration altogether. I think that's going to be the big change in a subset of our patients, is just being able to get away from needing to do androgen deprivation therapy.
I think that was an excellent answer. Thank you for elaborating on both of those things. In regards to your second point, and with your expertise in the immune system, and sort of to go off what I thought was an excellent description of the immune microenvironment for kidney cancer, do you see a future where, obviously biomarkers are the first step for each of these cancers of figuring out what to do, but do you see a future where the next step is taking those biomarkers and then manipulating these microenvironments and potentially potentiating these microenvironments, whether it be through macrophage depolarization, whether it be through T-cell trafficking, turning an immune desert into an immune oasis, if you will. Is this in the future? Is this in the distant future? Is this in the near future? Maybe speak to prostate cancer in particular, but certainly for all of these cancers.
Yeah, absolutely. I think it's somewhere where we're further along in kidney cancer and bladder cancer than in prostate cancer. We've been seeing really exciting data from the CD70 CAR T-cell in kidney cancer. And they've done a lot of really good work in sort of separating out these different types of subgroups. And we see some of that also in our clinical practice when we think about who's most appropriate up front for ipi/nivo and who's an IO-TKI patient to start with. That's, I think, just the first step in terms of manipulating this microenvironment. CAR T cells in general in solid tumors have been really, really difficult to develop, unlike in certain heme malignancies, because we have this tumor microenvironment that we have to overcome. Sort of breaking through some of these barriers is really challenging, so they've done a lot of work in trying to do that and do these combinations. I personally, this is my bias, I'm really excited about the prospect of T-cell engagers across GU malignancies. We've been seeing a lot of them in prostate cancer that are in phase 3 trials, and we have them in kidney and bladder that are also progressing in phase 1 and 2. And I think those are really promising to alter the tumor microenvironment, because what you're doing is you're recruiting your body's own T cells. If you think about it, we've got 5 billion lymphocytes circulating in our body at any given time, and you can engage those and drive them into the tumor microenvironment. You can really turn a cold tumor into a hot one. We see that. We've seen patients with bone metastases that usually don't respond to immunotherapy across cancer types, in kidney cancer, in breast cancer, and prostate cancer, generally speaking, do really, really well. So I definitely think the future is twofold, exactly like you said. Selecting the patients who are going to do well, and then figuring out how to overcome that microenvironment in those patients who won't at baseline.
Great talk. Thanks so much. And I had 3 questions.
Okay.
One is your thoughts on bladder cancer screening. I'm surprised that in this day and age, with cell-free DNA, molecular markers, that a urine sample is so easy to get. You consider the benefits of Pap smears, Cologuard. I'm surprised there's not effective bladder cancer screening. My second question, you've alluded to a little bit, but your thought on the future of theranostics. The third question about management of legal metastatic disease.
Great. So the first question with regard to screening, I think it's a challenge that we've faced. It's a challenge we faced across different disease types, and some we've done very, very well in lung cancer screening, and some where we've really failed to do so. I think ovarian cancer or pancreatic cancer screening, and I think prostate cancer is the epitomal example of something where you've got a non-invasive biomarker that we, 25 years later, still can't figure out how to properly use in terms of screening. I think in the bladder cancer world, now that we're getting better with more specific testing in terms of cell-free DNA, and also there's interesting data now with extracellular vesicles and exosomes, where you've actually got these packages of DNA and RNA and protein that might be more specific than the circulating tumor DNA. I think we're actually going to do better in terms of those types of non-invasive biomarkers, and I think we'll get there. Your second question was on theranostics, future of theranostics. So this is one area where prostate cancer is certainly far ahead in terms of kidney and bladder with Pluvicto and lutetium. And I think we're just now getting to the point, there's a couple things. How do we use the therapies that we already have in hand, and what's the next generation going to look like? And I think we're only now getting better with figuring out how to use Pluvicto in whom and when. So there's data at, PSMA4 came out earlier this year. It's now been approved in the pre-chemotherapy castration-resistant setting. PSMA addition showed in the hormone-sensitive setting an improvement in progression-free survival, but not actually as strong of a benefit as we would have hoped to see, and unclear yet if we're going to have an overall survival benefit there. And there was an interesting study at ESMO that I think kind of didn't get as much attention, but it was a head-to-head comparison in early MCRPC of lutetium versus docetaxel, and it was actually quite equivalent. It was actually very, very similar. And we saw the same thing in the therapy study where it was similar to cabazitaxel as well in terms of overall survival. So I think it's a great drug. It's a matter of, it's not the silver bullet or the magic bullet that sometimes our patients were thinking a couple of years ago. It's a matter of figuring out whom to give it in and when. I've shifted my practice patterns with Pluvicto. I'm using it more in the pre-chemotherapy setting and seeing less myelosuppression and better outcomes in those low volume, those good prognostic patients who are going to do well. Starting to re-challenge more, do more dose hold. I think we're figuring out how to give it. And I think the future is going to be, so that's just one target. It's PSMA. It's not the most specific targets. We have to deal with xerostomia. We have to deal with other side effects with it. So I think we're going to do better in terms of more specific tumor targets. STEAP1, KLK2 are really exciting ones right now. And better emitters as well. So alpha emitters seem to be really promising. There's multiple alpha emitters out there. And what's really cool in theranostics is they have all types of I'm not a nuclear physicist, but all types of new radioisotopes with lead and Auger radiation that's more specific and decays in different ways. I think it's a really exciting field, but we're going to face the same problem, that if we end up with 3, 4, or 5 different radioligands, we've got to make sure that we know how to how to put them together and select the right treatments in combination and in sequence. Your third question was on oligometastatic disease. And this is something that we always argue about, that what actually is oligometastatic disease and what's the definition? We commonly say that, it's less than 5 metastases, or, we have some radiation oncologists that say anything that I can radiate we'll consider oligometastatic. And this is something that's also changing as we're moving away from, as we're evolving beyond conventional bone scan and CT scan toward PSMA PET scan and other types of imaging. We're detecting more oligometastatic disease. The oligometastatic paradigm, clearly there seems to be a benefit when we radiate them. And there's evidence, we and others have done some studies that there actually is some modulation of the immune repertoire as well, and so that might help explain some of the longer-term benefits that we get. But I think where we're really struggling as a field is defining who that patient population really is and designing the right endpoints for them. This is something that Prostate Cancer Working Group 4 is trying to do, and that should come out a little later this year. But even that, we haven't figured out how best to monitor PSMA PET scans and what really we ought to consider as response or progression on those. So they have rules that they're coming out with, basically looking at the number of lesions and how many lesions count as progression, how many lesions count as require a confirmatory scan. So I think it's something that's really being worked out. There's clearly a benefit in oligometastatic. It's a matter of defining what that is and figuring out the right endpoints. I hope that answered your questions.
Thank you very much for this nice update. So actually, while I'm lung cancer, I spent most of my life treating lung cancer as my main focus. The last few years, I have seen more prostate cancer than lung cancer. And that's because of probably of our late CEO, may his soul rest in peace, who had prostate cancer, and he was over in the media frequently and so on. But also there is a big need in the community. And the most, so I have two issues I'd like to see if you can expand on them. One of them is that the most common question do I go radiation or chemo? Or surgery.
Mm-hmm.
Okay, that's the second thing. There is extremely lack. So my question about that, okay, you can tell me how you think about it. But when do I tell them you need to see a medical oncologist? They come to us because we are neutral. We don't treat, number one, and we can. But when do you tell them which disease subtype? You tell them you have to see a medical oncologist. And actually, this is part of the way that there is a lot of or lack of a progress as expected in molecular targeting, because they are not seeing oncologists up front, and they come to us when they have spinal cord compression or something like that in the past. So that's number one. The second question is, there is extremely lack of proper or at least by guideline use of genetic testing, all of it, the germline, the prognostication, and the somatic testing. So how you position these genetic testings, in your practice?
Yeah, no, those are two very great points. And so to the first one about when should our patients be seeing medical oncology? It's a fact that the majority of patients with prostate cancer are being treated in the community by urologists, and our urology colleagues are comfortable prescribing ADT. They're comfortable prescribing ARPIs to a certain extent. But as you correctly pointed out, that I think there are things that are better managed by a medical oncologist. It's a tough question to answer because as I'm sure all of us are feeling, we're bursting at the seams in terms of our clinical volume, and so when really is the right time to see them? In our practice, we try to see all of our patients with high risk localized and above, so we can really have that discussion with them about intensification with abiraterone or not, and have that decision about surgery versus radiation. So I'm fully with you. I'd love to see those patients sooner, before they're basically being referred to me for docetaxel. The challenge is going to be the healthcare capacity. and having the capacity to do that. And I think that in reality, what should happen, because we can't see all of those patients, is going to be, I think, better partnership with our colleagues in the community, with the urologists, with the radiation oncologists, and e-consults or advising from afar and saying, we're happy to come in if you need us, or have an initial consultation, but do make sure that we do the genetic testing and the somatic testing. So that getting to your second point, that we are under testing, and there's many barriers for that. Number one is the sites, clinics that if you don't have a dedicated genetic counselor, and most don't, you're having that discussion yourself, and that takes a lot of time. There's issues with the infrastructure about getting the blood testing, getting the tumor testing. Reimbursement issues are a problem. And so this is another one that's not an easy one to solve, and comes down to capacity. We're obviously very fortunate we have the resources to do that, but making sure that we resource our clinics appropriately to do that genetic testing and do it up front. Particularly now, I think that we have data in the hormone-sensitive setting that early on these can change management. I think this should also help from a reimbursement standpoint as well.
So what is the ideal implementation of genetic testing?
So what I teach my fellows, and straight from the NCCN guidelines, is that basically high risk and above all needs genetic testing, and we aim to do it at the first visit.
So this is the germline.
Germline.
Okay. What about, you probably are not involved in the prognostication testing like Decipher and all of these things?
So we use it so I don't see too many patients with intermediate risk localized disease. I use it in those patients, Decipher, Artera AI, as we're having that discussion about whether or not to do the ADT, whether or not to, and actually lately to having discussion even about active surveillance. So it's something I hadn't used much of, but I'm starting to use it more.
Yeah. So actually, just for the audience here, in CCA we have access to all genetic testing, and actually we have even funding from a generous donor to pay to defray any cost, any expenses that the patients may encounter.
That's great.
For genetic testing. So I just want to mention this resources for the community.
That's so important.
So I guess I have two quick questions just from a selfish perspective, but also looking out for Dr. Kamachi. With increased use of radiation with prostate cancer, especially seems like it's maybe moving front line, do you expect any changes in risks of MDS, mutation TP53? Again, looking after Dr. Kamachi. And then my other question is, I know you're speaking about CAR-T coming into the kidney cancer world. When are you expecting approval for that? Are we still 5-10 years away or sooner? This is selfishly to plan for myself.
So let me answer the second question. I think we're a good 5 years away. We're still in phase 1 with CAR-Ts. With respect to the radiation, so radiation for localized diseases has always been there as part of the treatment. And if anything, I think in that setting, we're actually starting to de-escalate radiation a little bit. We're moving from conventional fractionation, 78 gray, 35 fractions, down to 5 fractions of SBRT to the prostate. So if anything, we might be doing better in that respect in terms of radiation exposure. What we are seeing more of is in the oligometastatic setting, probably more radiation to lymph nodes and to bones. What's interesting about radiation to prostate cancer bone mets is that they're actually very radiosensitive. So we're usually talking about SBRT in very short courses, and so I don't expect that we should be seeing greater increases in therapy-related MDS with that.
Audience, any other question? Last one, I just wanted to ask you. There's a question. Oh, go.
Sorry.
No, please.
So we got some pretty good data at ESMO for another neoadjuvant approach with Pembro and enfortumab. That was very impressive PAT-CR rate, specifically cis-ineligible population, but very impressive PAT-CR rate. So kind of your vision on the new paradigm, could that be an all-newcomer approach for everybody? And two, really good info on the prognostic information on ctDNA and how you're kind of using that in practice to kind of your adjuvant approach in those patients.
Yeah. So our group has definitely started to use it, And we just had a big discussion on that ESMO data last week. I think it's a big paradigm shift, and I'm excited to see it. Ours is one of those groups that was still using a lot of dose-dense MVAC in the neoadjuvant setting, and I think moving toward a chemo-free approach is going to be great, and I really think that's the direction we're moving. And our group is using a lot of Signatera and ctDNA to stratify those patients. So we've adapted that pretty quickly.
So if it's negative, so if CTDNA negative, what do you do? Just
Yeah.
do it mentally for us in a simple way. What do you do?
So if the ctDNA, well, let me put it this way: we're not at a point. Yeah. Yeah, so we're not at a point yet where we're saying they're ctDNA negative, they're not going to go to radical cystectomy. I don't think we're there yet. We're using it a lot more for monitoring, for recurrence monitoring, but we're not yet using it, I think, to guide our therapy.
But if somebody's CTDNA negative, why would you expose them to cystectomy? I mean, these data.
So because we don't yet have the data on the outcomes without cystectomy. That's my view.
Can I?
Few patients, so that they are positive, I mean, they're negative, they eventually come back with the disease.
Correct.
So that is also plays a role. We haven't clarified that, so that's the reason probably.
For sure. If they're positive, it's going to come back, right? If they're negative, I don't think I think the data is very promising. Yeah.
What I'm saying is that I'm not saying not to treat,
Yeah.
but you know,
I'm glad we're having this conversation and to put it on the microphone in case people in the back can't hear. I think the question is when we get ctDNA clearance in a neoadjuvant bladder space, and the patients, and I'm sure any GU oncologist who's seen this patient, you all know they will be telling you, please do not take my bladder out. Do not tell me to have my bladder taken out. This is a very real fight that we will all be having to figure out because of the morbidity associated with this. And I think this brings the larger conversation maybe for the entire conference today as ctDNA data emerges in colon cancer and bladder cancer and is clearly powerful in solid tumor malignancies. And we start checking these things I don't know, I have patients who try to check it every 3 weeks. As oncologists, it is an enormous challenge I'm finding to know what the heck to do as the patients have access to this data that is clearly important, is clearly powerful, and I think this is going to continue to bring complicated conversations that we are not used to having per se, and it will also probably cause fights with our surgical colleagues who will say, no, take this thing out, and the patient will say, do not. So I've had this happen many times already, and I guess, have you guys as a group talked about when patients say, I want ctDNA testing every 3 weeks, I want it every month for the rest of my life, what do we do with this? It's wonderful we have it, but pragmatically, what do we do with it?
It's just like my patients who want to get weekly PSA testing, and we just have to follow the data, and that's what we tell them. This is the data that we have, and this is what's recommended. And we try to use a lot of that same conversation that sometimes you can see a little bit of fluctuations, and it can generate more anxiety than is actually warranted. It's actually the reason we got rid of ultrasensitive PSAs in our institution. That's how we try to. It doesn't always work, and a lot of them find a way to get that testing done anyway. But that's what we're doing. But I'm with you that I think it's really promising. I don't think we're quite there yet where we can start foregoing cystectomy in those patients.
For the sake of time, we have a last question.
Yeah, thank you. It's related to ctDNA because that's been a bane of my life also. I only do breast and lung, and it's permeating there. And patients insist that I draw it, and I refuse. And I tell them that decades ago, there were bone marrow biopsies done on women with a bunch of positive nodes with breast cancer, and those who had cytokeratin positive cells in the bone marrow, i.e. metastases, micrometastases, they didn't all uniformly relapse and die of breast cancer. So if a less sensitive test was meaningless, why would I do a more sensitive, meaningless, more expensive test today? And I say, if you can't unshackle somebody from the train tracks, you don't buy them binoculars. That's the analogy I give them.
That's a great one.
So what is the value of drawing this in the absence of a survival advantage? That's my question.
Yeah, no, I think it's something that we need those prospective studies to really validate it. I think we're at a point now that we clearly have a signal. It's clearly worth studying further. But I agree with you. I think until we really know for sure, until we have it randomized phase 3 level evidence, it may not be something that should be widely done, at least in this setting.
Thank you.
Can I make a comment, quick comment? I think the issue is, as clinicians, we don't go into the lab. We see a test and we believe it, right? And the problem with ctDNA is that in 2025, it's not sensitive enough, all right? So if it's negative, it doesn't mean that your disease is completely cleared. Charlie, now it's lung cancer, it's not a GU, but Charlie Swanton in UK, who's done a lot of work, he has a paper that's coming out in Cell, where they've done a large study, and the conclusion is that the tests are not there yet, and so that's really the big problem. When we get to a point where a negative ctDNA really means that we've cleared all the disease, then we can make the decisions. But until then, with the tools that we have, as you said, I agree, we have to do the prospective studies and figure out what you do with it. But I think we'll get there. The tests are getting better.
I agree. It tracks so closely with the burden of disease, and in many ways, we're repeating the same lessons that we had from circulating tumor cells a decade ago.
Thank you.
Thank you.